So usually the longest nerves are affected first. That's why the symptom starts from the feet or toes first. And symptoms of an underlying systemic disease can be assessed by a good clinical history, and you need to search for the etiology. A good history is always a cornerstone of diagnosis, and if there are certain symptoms present which are suggesting some systemic illness, for example, like connective tissue disorder symptoms in a young female, so neuropathy can be secondary to that. You have to search for the etiology and work up accordingly. Or if symptoms are suggestive of diabetes and patient is still undiagnosed, it's probably diabetic neuropathy, and you need to work up for diabetes. And if he's already diabetic, then definitely most probable causes diabetes. So the types of nerve damage include demyelination, axonal damage, and neurotomesis. Demyelination is actually slowing of the conduction velocities. Initially, there can be no symptoms. When there are conduction blocks, then there can be weakness and sensory impairment, but in demyelinating type of neuropathy, usually the atrophy is not present, or if it is found, it is usually late in the course of the disease due to disuse atrophy, because there is no denervation, there is slowing of the conduction velocity and there is conduction block. In axonal damage, there is degeneration of the axon distal to the lesion, so there is denervation of the muscles, and wasting can be found early in the course of the disease. Motor weakness, sensory impairment, and muscle atrophy can be present. Neurotomesis is actually damage to the axon and epineuron. It's usually traumatic in origin due to nerve lacerations, and the symptoms are same: weakness, sensory impairment, and atrophy, and there is no degeneration without the nerve suture, the surgical approach. As far as classification of polyneuropathies is concerned, these can be classified in several ways. Like these can be classified according to their clinical presentation. If the presentation is symmetric or asymmetric, both have different causes. Time course, acute or chronic. As you know, in acute we consider GBS and porphyric neuropathies, and in chronic the example is the chronic inflammatory demyelinating polyneuropathy, diabetic neuropathy, neuropathy secondary to CKD, or some other vasculitis and connective tissue disorder. You can classify according to etiology, and you can classify according to pathology, that is either it is an axonal neuropathy or demyelinative neuropathy, or it is a small fiber neuropathy. Small fiber neuropathies, they present only with sensory symptoms, and most of the time the examination also doesn't yield any abnormality, and these are diagnosed on the specific nerve conduction studies. Usually the motor weakness is not there because this is pure sensory type of neuropathy. The clinical forms, chronic, symmetrical, distal, and predominantly sensory polyneuropathies can be there, just like a diabetic neuropathy. Mononeuritis multiplex can be there, like in vasculitis and sarcoidosis, in which different nerves can be involved and in different extremities, like foot drop on the right and wrist drop on the left, like common peroneal nerve palsy on the right lower limb and radial nerve palsy on the left upper limb. So this is how the mononeuritis multiplex present. It can be due to diabetes even, and many other causes. It can be either purely motor, either purely sensory, or maybe sensory motor, and there are then autonomic polyneuropathies. So the symptoms of polyneuropathies course is variable. It can be acute, subacute, or chronic. Symmetric in presentation mostly, with distal paresthesias, pain and hyperesthesia, and stalking and glove distribution, and feet are affected first. Allodynia can be present. Allodynia is painful perception of pain in response to a non-painful stimulus. This is what we call as allodynia. Depressed or absent tendon reflexes, distally pronounced muscle weakness, with vesting and fasciculation. Vesting and fasting more common with axonal neuropathies, and it can be present in demyelinating when it's longest standing demyelinating polyneuropathy. Fasciculation, when there is too much muscle atrophy, then fasciculations can also be there. Gait disorders, patient may have sensory ataxia, and the sensory ataxia, the cause is involvement of the large nerve fibers, and these and the dorsal roots, they carry the proprioception and vibration sensation. So when these nerve fibers are affected, patient can have impaired proprioception and vibration, which can be picked by doing the Romberg's test, or either you check for the vibration and position sense during your lower limb examination and upper limb examination. Autonomic dysfunction can be depicted by reduced sweating, tachycardia, urinary disturbances like retention, gastroparesis, And autonomic dysfunction is very common in long-standing diabetes. The typical complaint of patients with polyneuropathies, they describe it in very different ways, like tingling or pimpling or numbness, or burning or cold sensation, or the burning pain, especially during nighttime in the extremities, starting with the feet, and swelling on my legs, like, and then as if I had tight boots on, like if I was walking on a duvet or walking on cotton under my feet, or if I had stockings on, then I really hadn't. As if my skin was thick on my soles, unstable gait, dizziness, loss of dexterity of the hands. They drop the objects, so the motor power is normal, but they may drop the objects even if there is sensory impairment or proprioception impairment. Motor power can also be impaired in certain neuropathies with the passage of time. Then causes of polyneuropathy can be metabolic or endocrine disturbance like diabetes and uremia. Vitamin deficiencies like B1 deficiency, alcoholism leading to B1 deficiency, malabsorption, malnutrition, B12 deficiency, toxins like heavy metals and industrial solvents and certain drugs and alcohol. Immune mediated with manifestation only in the peripheral nervous system like AITP, just GBS, and CIDP and multifocal motor neuropathy. Systemic diseases like vasculitis, polyarthritis nodosa, SLE, vaginal granulomatosis, they do have their systemic manifestations accompanied. Paraproteinemias like multiple myeloma and Waldenstone microglobulinemia, they can have neuropathy as part of the disease and paraneoplastic neuropathies. Then we have infectious causes like leprosy, and leprosy it usually presents with mononeuritis multiplex. Lyme disease usually with polyradiculopathy. HIV can present as either a polyneuropathy, sensory or sensory motor, both are possible. Then we have hereditary Charcot-Marie-Tooth disease. Then we have others like critical illness polyneuropathy. This usually develops in patients who have been on ventilatory support with sepsis and multi-organ failure, and there are multiple factors which are leading to neuropathy, and this is called critical illness neuropathy. Then we have small fiber neuropathy, as I've already told you, manifesting with sensory symptoms. And then we have a certain percentage, like 30% of the patients in whom no cause of the neuropathy is found, and they fall in the category of idiopathic. Now, how do you investigate a patient of polyneuropathy? First of all, we need to do the nerve conduction studies on EMG to categorize whether it is axonal or demyelinating or a small fiber one. Then we go for blood workup like CBC, blood sugars, renal function, liver functions, glycosylated hemoglobin, vitamin B12, thiamine level, not being done in Pakistan, but these are also recommended. And thyroid function test, serum protein electrophoresis, autoantibodies like ANA, anti-dsDNA, cryoglobulin levels can be done. In hepatitis C, cryoglobulinemia can cause neuropathy. Serological examination like HIV, Lyme, and hepatitis C. We can look for tumors if the history and symptoms are suggestive, and we can do CSF analysis, and if any toxin is suspected, we can investigate for that. We can do sputum nerve biopsy to look for demyelination, onion skin pattern on biopsy, and we can do genetic testing when we're suspecting hereditary neuropathies. So the treatment of polyneuropathies, the tagline is treat the cause. Treatment of polyneuropathies is always treat the cause. Symptomatic treatment is there, like for paresthesia and neuropathic pain, we can use different drugs, but the treatment is always of the underlying cause. Like in immune therapy, we use in GBS, like NCIDP, we use plasmapheresis and IVIG, and also in GBS, CIDP, and multifocal motor neuropathy, we use IVIG. Corticosteroids can be used by CIDP and systemic vasculitis. And then symptomatic treatment with anti-epileptic medication, gabapentin and pregabalin for the sensory symptoms, and even TCS, tricyclic antidepressant, can be used, and serotonin and norepinephrine reuptake inhibitors like duloxetine and venlafaxine can also be used for sensory symptoms, painful sensory symptoms. Vitamin B1, alcoholism can be caused because of alcoholism, malabsorption, malnutrition, so we have to find out the cause and correct it. Now coming to Guillain-Barré Syndrome or GBS, it is an acute inflammatory demyelinating polyneuropathy, a disorder affecting the peripheral nervous system. It is sometimes called Landry's paralysis because he was a French physician who first described a variant of it in 1859, and it is included in the wider group of peripheral neuropathies. Now, one thing has to be clear, it's not necessarily demyelinating polyneuropathy. Mostly it is demyelinating, but it can be axonal, and there are multiple variants of it. It includes AIDP, that is the typical variant. Then we have acute motor axonal neuropathy, that is the AMAN variant. Then we have AMSAN variant, acute motor sensory polyneuropathy. Then we have Miller-Fisher variant. So this has many variants. AIDP is one of these. The etiology is unclear, but an autoimmune response is suspected. There is preceding event or trigger event that is often an infection, maybe vaccination. Now 70% of cases they are post-infectious, and you may get a history 1 to 3 weeks prior to the onset of neuropathy of an acute infectious process like respiratory or GI infection. 20 to 30% cases are due to Campylobacter jejuni that causes a diarrheal illness, and other agents like human herpes viruses, EBV, Epstein-Barr, and cytomegalovirus. Then we have Mycoplasma pneumoniae also associated with GBS. Recent immunization, swine influenza vaccine, H1N1, older rabies vaccine can be seen in patients with lymphoma, HIV positive, and SLE, but then it is not pure GBS, but it is part of the underlying disease. It can be treated with the immune modulating because the pathogenesis is same, so it can be treated with plasmapheresis in even these cases. It is an autoimmune-based pathogenesis. Both cellular and humoral immunity are involved, and they result from immune response to non-self antigens like infectious agents or vaccine that misdirect the host nerve tissue through a resemblance of the epitope. This is what we call as molecular mimicry. And it also involves T-cell activation, interleukin-2, 6, TNF, and neural targets are gangliosides, and anti-ganglioside antibodies, TM1 antibodies, are present in 20 to 50% cases which are associated with Clostridium jejuni, and anti-GQ1B antibodies are present in more than 90% of Miller-Fisher syndrome. Myelin sheath surrounding the axon is lost. It occurs in demyelination, and besides demyelination, this is demyelination. As you can see, the damaged myelin and the exposed nerve fiber. In the syndrome, as I told you, it can be axonal as well as demyelinating. So demyelinating is a pathognomonic of GBS, but it has now axonal variants also. The syndrome may develop rapidly over the course of hours or days, or it may take up to 3 to 4 weeks to develop. Weakness or symptoms can progress up to 4 weeks. Most patients will demonstrate the greatest weakness in the first 2 weeks of the disorder. A flaccid ascending paralysis is developed. What is ascending paralysis? Paralysis or weakness starts from the lower extremities and gradually it progresses to involve the upper extremities. It can also affect the trunk. There can be truncal weakness as well. The patient is most commonly affected in a symmetrical pattern. There is no fever at the onset of weakness. If there are fever and systemic symptoms at the onset, these cast doubt on your diagnosis. These should be absent if it is pure GBS. The patient may first notice weakness in the lower extremities. It may ascend to include the upper extremities. Tendon reflexes are usually diminished or lost. Even in the earliest stages, the trunk and cranial nerve may become involved, and the most common cranial nerve is facial nerve, which is involved. And bifacial weakness can be present in up to 50% of the patients, and sometimes there are lower cranial nerve are also involved, which causes dysphagia and difficulty in swallowing and also speech. And respiratory muscles can become affected, resulting in respiratory compromise. Autonomic disturbance like urinary retention, tachycardia, fluctuations in BP, and orthostatic hypotension may also occur. Bladder dysfunction occurs only in severe cases, and it's always temporary or transient. It resolves within few days. If the bladder dysfunction is a prominent feature, it comes early in the course. Think about other pathologies than GBS, for example, spinal cord disease, which may be myelitis or which may be cord compression. Sensory symptoms of paresthesias, including numbness and tingling, may occur. Pain is a complaint in a large number of patients, and aching pain, it may be backache, it may be myalgias. And if there is cranial nerve involvement, again, facial nerve is the most commonly affected, and it typically does not affect the level of consciousness, pupillary function, or cerebral function. But there is one cause due to which GBS patients may be having altered level of consciousness. It's necessary to mention. It can be SIADH. Sometimes hyponatremia secondary to SIADH is present, and it may lead to altered level of consciousness. Symptoms will progress for 4 weeks. The level of paralysis may stop at any point. It's not necessary for the symptoms to progress till 4 weeks. In some patients, they The weakness is maximum in 1 week and then it stops. So it depends. It's variable from patient to patient. Motor function returns back in a descending fashion, and demyelination occurs rapidly, but rate of demyelination is 1 to 2 mm per day. That is some histopathological evaluation. Then we have Miller-Fisher variant, and which occurs in most adults and children both, and there is a triad which is typically associated with it, that is ophthalmoplegia, areflexia, and ataxia. These three are the characteristic of Miller-Fisher variant, but this triad is present only in 25% of the patients. So patient may have either two of these symptoms. There may be areflexia, ophthalmoplegia, there may be areflexia or ataxia, there may be ataxia or ophthalmoplegia. Ataxia is most of the time sensory ataxia. Okay. Now, the anti-GQ1B antibodies are present in more than 90% of the cases, which are not seen in other form of GBS unless there is extraocular muscle involvement. Extraocular muscle when involved, sometimes the GBS, it overlaps with the Miller-Fisher. There is combination of GBS with Miller-Fisher. In that case, you may find Miller-Fisher syndrome. Motor weakness is not a feature of Miller-Fisher. It is ataxia, areflexia, ophthalmoplegia. And pupillary paralysis can occur, and only 5% of cases of GBS are of Miller-Fisher type. Regarding the differential diagnosis, there is a long list. First of all, acute myelopathy has to be differentiated, which I have discussed in my region localization. They can present with backache, they can present with dominant sphincter disturbances, there can be sensory devils, you can get upper motor neuron sign in that, like absence of plantar. Botulism, there is early loss of pupillary activity, there is paralysis is descending. It starts from the extraocular muscles, and then dysphagia develops, and then upper limb weakness, and then it is progressing toward limb weakness. It's opposite to GBS. Diphtheria, that is a very different onset. The onset is with just neck pain and the throat pain and the formation of membrane in the throat, and dysphagia and odynophagia at the onset. Patient may have nasal regurgitation as well early in the course of the disease, and then this all subsides. There can be neck swelling also. All this subsides. There's a gap of weeks between the onset of neuropathy and these symptoms of diphtheria. So it's very clear from the history. The Lyme disease, they have other systemic manifestations like joint pains, rash, and it is actually a polyradiculitis rather than polyneuropathy. Porphyria patient will have abdominal pain, they can have seizures, they can have psychosis, and vasculitic neuropathy, you may get symptoms of different connective tissue disorder or vasculitis from the history. Poliomyelitis, well, it can have fever and signs of meningeal irritation like aseptic meningitis can accompanied by brainstem ischemia. Again, it will be very sudden in onset first of all, and then you will have upper motor neuron sign. Patient may have altered state of consciousness depending on part of the brainstem involved, and you may be able to fit that presentation into one of the brainstem syndrome like lateral medullary syndrome or Lockman syndrome or medial medullary syndrome. Then we have critical illness neuropathy already discussed. Myasthenia gravis. Myasthenia gravis is a progressive disorder. Usually the onset is not very sudden over days to weeks, but is usually there's history of months, and there is prominent ocular involvement, and there is prominent history of fatigability and fluctuation in the weakness. Then comes the organophosphate, and yes, reflexes are intact in myasthenia gravis. They are never lost. Organophosphate poisoning, there may be history of organophosphate ingestion, and there will be cholinergic symptoms like excessive lacrimation, and diarrhea can be there, bronchoria can be there, excessive bronchial secretions can be there, fasciculations can be present. So the diagnosis, the history, the onset of a symptom can be revealing, because symptoms of GBS usually begin with weakness and paresthesia of lower extremities, and they ascend in a symmetrical pattern. The lab features, we do the CSF analysis, which show raised proteins, which can be from 100 to 1000 mg%, and without pleocytosis, usually the WBC count is normal, that is 0 to 5, and this is called albuminocytological dissociation. Proteins are raised, but cells are not. Increased protein at the end of the first week, these are common, and in the very first week, CSF analysis can be completely normal. And if there is significant pleocytosis, always think about infective causes like HIV, CMV, or maybe some vasculitis. Electrodiagnostic tests include EMG and CS. These may be normal in first week, and they lag behind the clinical event. In demyelination, you get conduction block and slowing of the conduction velocities, prolonged distal latencies, while in axonal pattern, you can get reduced amplitude of compound action potential without conduction slowing. Respiratory muscle involvement can occur, and pulmonary function tests are done and GBS is suspected to establish a baseline of comparison. As the disease progresses, vital capacity is monitored regularly. Declining pulmonary function capacity may indicate the need for mechanical ventilation and management in the ICU. From the management, first of all comes the general management, that is admitting the patient in an ICU care preferably, and providing nursing care and fluid balance, care of the bowel and bladder, DVT stockings, DVT prophylaxis with low molecular weight heparin, and then we get a specific therapy for these patients. The first therapy which is proven to benefit patients is plasmapheresis. Before IVIG, plasmapheresis was the first therapy with a proven benefit, and we do it 50 ml per kg per day plasma exchange on alternative days to complete 5 sessions. And there is no benefit of more than 5 sessions. IVIG is also useful in managing GBS. The result or the outcome of IVIG and plasmapheresis is same, and the only difference is that plasmapheresis needs invasive procedure. It requires a double lumen catheter placement, and then there is the plasma. We do it on alternate days for 5 days, and there are certain complications like in hemodynamic unstable patient, there may be problems, and the DL, the double lumen catheter, can cause endotoxemia, infections acquired from the hospital. While IVIG is non-invasive, it is given like an IV infusion again. So there is no placement of any catheter, no need of any plasmapheresis machine. But the problem is that IVIG is very costly, while plasmapheresis is relatively less costly. And IVIG is contraindicated in those patients who are deficient in IgA. We do the IgA levels before we give any patient IVIG. Now coming to the outcome, 65% they can walk independently for after 6 months. Overall, 80% they usually recover completely, and some have residual disability. 5 to 10% they may have prolonged course with incomplete recovery, and 3% are wheelchair bound for the rest of their life. Approximately 5% they die despite the ICU care, and 2% if they develop chronic relapsing pattern, like first they have GBS and then again repeatedly they have similar episodes, they can develop CIDP, chronic inflammatory demyelinating polyradicular neuropathy. GBS is usually a monosymptomatic illness, but in 5% of the patient it can be recurrent. It can be recurrent, and if it is recurring again and again, then it is CIDP. Now we will discuss few things about hereditary sensory motor neuropathies. This is a case scenario of a 14-year-old girl who presented with the complaints of progressive weakness of the legs, progressive deformities of feet and hands since the age of 4 years. On examination, there is claw hand, there is foot drop and base cavus deformity. Deep tendon reflexes are absent, and touch sensations, they are diminished in the lower extremities. You can see this is base cavus deformity, there is vesting of the distal leg muscles, and there is claw hand deformity. This is Charcot-Marie-Tooth disease, HMSN type 1, genetically and clinically heterogeneous group of inherited disorder of the peripheral nervous system characterized by progressive loss of muscle tissue and sensory impairment across various parts of the body. And the prevalence is 3.8 in 100,000 patients. It is can be transmitted as an autosomal dominant, recessive, or X-linked type. X-linked in HMSN type 1 can be an X-linked transmission. It is a result of genetic mutation in a number of genes. Based on the affected genes, it can be categorized into types and subtypes. Actually, these are 2 main types, and there are almost 7 types of HMSN. Now, it is not called CMT, it is mostly called as HMSN or hereditary sensory motor neuropathy. Demyelinating type, type 1 is HMSN type 1 is demyelinating type, and it causes severe demyelination, thereby impairing the nerve conduction velocity. And HMSN type 2, that is hereditary motor and sensory neuropathy type 2, it is axonal. It mainly affects the axons. It tends to affect the lower extremities more than the upper extremities. Clinical symptoms are often less severe than in HMSN 1. As it is an axonopathy, then average nerve conduction velocity is usually not affected, but the compound muscle action potential amplitudes are reduced, while in type 1, the conduction velocity is reduced. Most patients, they are asymptomatic until late childhood or early adolescence, but young children sometimes they manifest with gait disturbance as early as the second year of life. And children with the disorder, they are often described as being clumsy or falling easily or tripping over their own feet. Onset of the symptom may be delayed until after the fifth decade, and this is mostly true for SNSN type 2. It can be late onset, it can be very, very slow in progression. Muscles of the anterior compartment of the lower leg, they become vested, and the leg have a characteristic stalk-like contour, or we can say inverted champagne bottle appearance. The muscular atrophy is accompanied by progressive weakness of dorsiflexion of ankle, and eventually it leads to foot drop. The process is bilateral, but it may be slightly asymmetric, but it's mostly symmetric. Pace gives deformities invariably develop, which include high arch of the feet and hematoes. Denervation. It is due to denervation of the intrinsic foot muscles, further destabilizing the gait. You can see this is space cavus deformity and vesting of the distal leg muscles in the anterior compartment of the leg. This is foot deformity. Atrophy of the muscle of the forearms in hands is usually not as severe as that of the lower extremities, but in advanced cases, contracture of the wrist and fingers, they produce a claw hand. And proximal muscle weakness, it is a late manifestation and it is usually mild. The weakness is mostly distal, and in these patients, axial trunk muscles are not involved. This is claw hand deformity with vesting of the hand muscles. Autonomic manifestation may be present as poor vasomotor control with pallor of the skin of the feet and inappropriately cold feet. The sensory involvement, it mainly affects the large myelinated nerve fibers that convey the proprioceptive information and vibratory sense. So there is, if there is any sensory impairment, it is usually impairment of the proprioception and vibration. So rhombus can be positive and proprioception and vibration sense can be impaired. But in some cases, you can find that there is decreased pain and touch sensation, also glove and stocking pattern type. Some children, they may complain of tingling or burning sensation of the feet. Pain is not common. Because the muscle mass is reduced, the nerves are more vulnerable to trauma and compression. And in these patients, the nerves, because of the lost muscle mass, and the demyelinating, especially the type 1 demyelinating type of, there is demyelination and remyelination. So the palpable nerves can be found. And the common site to find or examine on examination these palpable nerves is behind this elbow and at the level of fibula. Common peroneal and ulnar nerves, these are commonly, and the great auricular nerve behind the ear, these can be thickened and these can be found on palpation. Now the distal deep tendon reflexes are lost. Involvement is mostly distal. It starts distally, so gradually, first of all, the distal deep tendon reflexes are lost, and the disease progress. Even the proximal ones can be lost. But proximal muscle involvement is not common and it's very rare. Cranial nerves are not affected, not even facial nerve. The sphincter control remains well preserved. There is no sphincteric involvement. Autonomic neuropathy like GBS or diabetes, it does not affect the heart, GI or bladder. Intelligence is normal in these patients, and a unique point mutation in PMP2 gene, it causes progressive auditory nerve deafness. This is usually late in onset, and it is present in one variant of HMSN. Left findings and diagnosis, again motor and sensory nerve conduction, we need to do EMG and muscle biopsy can be done, nerve biopsy can be done. Definitive diagnosis is based on genetic studies. We need a blood sample for genetic studies. Now the treatment is mainly supportive. There is no cure, there is no medicine which can halt the progress of the disease, so the main treatment modality is supportive measurements. Like stabilization of the ankle, it is a primary concern in early stages. Stiff boot can be advised, lightweight plastic splints can be used, and external short leg braces may be required when foot drop becomes complete, and surgical fusion of ankle may be considered in some cases when they develop certain complications. The leg should be protected from traumatic injury, and in advanced cases, compression neuropathy during sleep may be prevented. Like if these patients are bed bound and they have little muscle mass left, this common peroneal nerve can be easily compressed and it can worsen the foot drop. So we can prevent it by placing the soft pillows beneath or between the lower legs. Burning and panesthesia, the feet are not common, but if these are present, it are similarly treated with the antiepileptic drugs like pregabalin or maybe the SNRIs and TCS. No medical treatment is available to arrest or slow the progression. So this was about general approach to neuropathies, Guillain-Barré syndrome, and